Hello, everyone. First, I would like to thank the organizer for giving me this opportunity to present some of the work that my lab has been doing. And today I'll be talking about the dynamics of HIV-specific antibody responses in individuals that start treatment in acute infection. And this is the mandatory acknowledgement and disclaimers. And I'm going to be starting my presentation by talking briefly about T-cell responses. So there's some very nice work that was done by Brad Jones in his lab, where they showed that in people that are virally suppressed, the T-cell responses are dynamic, and there's expansion of some T-cell clone over time, contraction of others, and very interestingly, NEF-specific T-cell responses show evidence of recent antigen encounters. And this is while people are suppressed. And these responses are associated with the size of the reservoir. So that suggests that even if the virus is not detectable in blood, there is some level of at least antigen exposure, maybe not viral replication, but antigen exposure, and that can shape the immune responses. On the antibody response side, most of these studies have been done in chronic infection. And the one example where I could find where people try to look early after infection is this paper here, where they included a group of people that started treatment within an estimated of 6 months after infection. And they compared the evolution of the antibody response to participants who started in the chronic stage of infection. So if we look in the middle first, we can see that the dotted line here represents when ART is initiated. There's a decline in antibody responses with some plateau at a somewhat high level. And in the early treated group, we see the same dynamics, but everything is lower in magnitude. And there's also a plateau, but it's at a very lower level. And these responses were associated with the size of the viral reservoir, as shown here on the right. So we are interested in studying these type of antibody responses in acute infection and what happens when treatment is started in acute infection. So for that, we use the RV254 cohort. It's a prospective study in Thailand that is enrolling participants with the acute HIV infection, and they're offered antiretroviral treatment immediately a few days after they are diagnosed with acute infection. So there's a high number of samples that have been screened and over 400 participants enrolled to date, with approximately half of them in phoebic stage 3 and about 1/3 in phoebic stage 1 and 2. So really, truly acute HIV infection. So the questions that my lab was interested in answering are, what happened to the antibody response over time when ART started this early after infection? And can we see any evidence that the antibody can put immune pressure on the virus? So to answer those questions, we selected 34 participants from RV254, and we looked at 3 different time points. So ART initiation, 12 weeks post-ART, and 2 to 6 years after ART. We measured binding antibodies by Luminex, and then we looked at 2 Fc-mediated function, antibody-dependent cellular cytotoxicity using some variation of the Pentox assay, and antibody-dependent cellular phagocytosis using fluorescent beads. And in both cases, we use a GP120 CM235 to perform both assays. Here you can see the demographics of the study participants. So it was a very homogeneous cohort. As you can see, most of the participants were relatively young, almost all males with the exception of 2 females, and all of them were phoebic stage 2 or 3 with one exception of a phoebic stage 1, and all had the CRP1 AE subtype. And this was on purpose because we wanted to limit the number of factors that could influence our results. And there was quite a range in the viral load at ART initiation, and that is shown on the right here. And in red is the median for the cohort. So there is over a 2 log of range of the viral load at ART initiation, and then you can see that they rapidly decline after treatment. And by month 8, about all the study participants are suppressed, and they stay suppressed throughout the duration of the study. And here you can see the 3 time points that we analyzed. So enrollment, start of ART, 12 weeks, and about 2 years after ART initiation. The antibody profiling was done by Luminex. And for that, we selected 29 antigens. So there was 4 GP120, 13 GP140, some V1, V2, and V3 antigen, as well as other controls. For today, I'm going to be presenting data only on one of the GP140. These antigens were then coupled to different beads, incubated with the plasma samples, and then we had 18 different detection reagents. We had Fc receptors, total IgM, total IgA, total IgG, and then the different IgG subclasses and complement. So this work was performed by Shelley Krebs' lab, and the data analysis was done by Morgan Rowland's lab, both at MHRP. This is the data for the binding responses to GP140 consensus CRF1AE. What you can see here is total IgG and then IgG1 and 3, and now they change over time. So there is an increase from enrollment at acute infection, and then following 12 weeks of treatment, we see an increase in total IgG, followed by a decline from 12 weeks to 2 years. We see the same pattern for IgG1 and 3. And you can also notice that there are some outliers where there's and the increase keeps going all the way to 2 years, like this participant and some others here. For IgM, what we saw is that there were few participants that were positive at enrollment. You can see the dotted line here is the threshold for what we would consider a positive response. And then after ART initiation, they decline, and then most of them become below the threshold for positivity, with this one exception here. And I'm going to come back later to that one study participant that is quite interesting. And then for IgM, the responses were very low and more or less around the threshold for positivity, with no significant change over time. Here you have the result broken down by PHIBIC stage 2 or 3. And what we can see is that at enrollment, the responses are higher in PHIBIC stage 3 compared to PHIBIC stage 2 for all of the detection reagents. And then we see the increase from enrollment to week 12. And at that point, there is still a trend that it's higher for PHIBIC stage 3, but it's not significant. And then we see then the contraction of the response up to 12 years. And for total IgG, it's significantly higher at PHIBIC stage 3, but not when we look at IgG1 or IgG3. Again, for IgM, we see that the few that are positive at enrollment are PHIBIC stage 3, and then they decline, and almost everyone then is negative. And for IgA, you can see that all the responses are about the level of the cutoff for positivity. There is no significant difference, except for at study enrollment, it is higher in PHIBIC stage 3. And these responses were not associated with the viral load at ART initiation or the area under the curve, as is shown here. So you have the change from study enrollment to week 12 in regards to viral load or area under the curve, and there's no significant correlation. And then when we looked at the FC function, here you have the result for ADCC on the left and ADCP on the right. We see a significant increase in ADCC from study initiation to week 12. And this makes sense because this is when we see this increase in IgG responses. And we didn't see a decline. We see more that these responses seem to be stable over time, up to 2 to 6 years. For ADCP, we saw that there was also a trend for an increase, maybe slower and not quite significant, but the proportion of study participants that were positive at year 2 was higher than at enrollment. So overall, the trend is also an increase for this function over time after ART initiated in acute HIV infection. When we compare the magnitude of these responses between FIBIC stage 2 and 3, we didn't see any significant difference at any of the time point, either baseline or week 12 or 2 years for both ADCC and ADCP. What we saw was that there's 3 different patterns. There were participants who were negative at ART initiation and then gained a function. There are those that were positive and then lost that function. And there are those that were either positive and negative and stayed like that. So this was by far the third pattern was the most prevalent, as you can see with the black part of the pie chart. However, in those that were positive, there could have been an increase in the magnitude. That is not represented here. Then for the one that were positive at ART initiation and then decline in function, that was really observed only once in a FIBIC stage 2 participant. And for the gain of function, we saw that with a slightly higher frequency in FIBIC stage 3 compared to FIBIC stage 2. As you can see here, 32% compared to 27% for ADCC, and some lower percentage for ADCP, but 21 compared to 13, again, slightly higher in FIBIC stage 3. And similar to binding antibody, these responses were not associated with viral load. So here you have at study enrollment, at initiation of ART, the ADCC or ADCP is not correlated with the viral load at the same time point. And we didn't see any association for any of the time points. We also looked for association at 2 years with the size of the viral reservoir, and we didn't find any significant association. So this was a bit in contrast to what was found in in chronic HIV infection, like I mentioned at the beginning of my presentation. And here I want to show more specifically one study participant, number 35, which was a FIBIC stage 3 participant, started with a fairly high viral load as compared to the median in red, but suppressed relatively well and relatively quickly and stayed suppressed over time. And what we found is that this participant had an increase in binding IgG and IgM over time, including from week 12 to years 2, when if we look from week 12 here to years 2, it was completely suppressed. So there was no evidence of viral replication in blood, but we see an increase in binding responses, in ADCP responses and ADCC responses in that study participant. So this suggests that even though we don't find evidence of viral replication, maybe there is some level of antigen exposure that is driving the evolution of these responses. And here I'm going to show one example from a treatment interruption study where we know that in this case there is antigen exposure and we see a rapid increase in antibody responses. And it's from a study where RV254 participants were enrolled and received either a vaccine or a placebo. And then there was a treatment interruption and there was a small delay in viral rebound in the participant that got the vaccine. But for today, I'm going to focus on the placebo to rule out any possible effect of the vaccine. And if you compare, here I'm only showing ADCP, but if you compare at the time of treatment interruption to the time of viral rebound, there's an increase in this function. We saw the same for other function and for binding antibody. So in conclusion, antibody responses are not static in people living with HIV that initiate treatment in acute infection. We see an increase in responses, both binding and functional responses, followed by either a decline or in some participants, a continuous increase. And I didn't present neutralization data in my presentation, but we did perform neutralization of tier 1 pseudoviruses with ART-resistant backbone. And we saw minimal to no neutralization across all the study participants. This is consistent with the fact that in untreated infection, you really need years to develop neutralization. So going back to the increase in function that we saw in some study participants, this really suggests that there is some level of antigen exposure despite suppressive therapy. And it doesn't mean there is viral replication, but just that there could be a production of viral antigen. When we know that in treatment interruption study, when there is antigen exposure, we see an increase in these antibody responses. And then in people living with HIV that are treated in acute infection, we didn't find any association between antibody or FC function and viral load or size of the reservoir. So this would potentially suggest that antibody put minimal to no pressure on the virus during acute infection. And when treatment is initiated in acute infection, if we want to leverage antibody for a cure, then we would really need to boost this function, these antibody responses significantly to be able to put immune pressure on the virus. Finally, I would like to thank everyone who performed the work in the lab, Bonnie and Ursula, Barbara, Aljara, and Jana, and then Tenbi and Morgan for the data analysis. And of course, all the study participants from RV254 and RV405, and everyone who was involved in this study. There's really a lot of people who help conduct these studies, and it really takes a village to perform this type of work. And without everyone listed here, these type of studies would not be possible. Thank you.